Hi, everyone. Thank you so much for joining the seventh and final webinar in the Telehealth series hosted by the Delaware Healthcare Commission. My name is Amanda White. I'm a senior consultant with Health Management Associates and have been providing support to this webinar series. Today, our webinar is going to be focused on use cases from the field. We've invited Beverly Lawson, Director of Treatment Services for People's Place, and Tracy Bolander, CEO of MidAtlantic Behavioral Health, who have both graciously offered to be interviewed for this webinar. My fellow colleague, Dr. Uche Uchendu, principal at HMA, will be the main facilitator and the person conducting the interviews. So the first part of this webinar will be a look back at highlights from the previous webinars that we've had in this series, and then the second part is going to be the actual interviews with Beverly and Tracy. So before we go ahead and get into the slides, just a friendly reminder that your phones should be muted during the presentation. But if you guys have any questions or comments throughout the webinar, please do feel free to go ahead and type them into the chat box. So next slide. So this is an overview slide of the series and just speaks to the origin of telehealth and how it aligns with BHI activities and addresses specialty care clinician shortages along with other concerns that have been identified with system transformation work. Next slide. This is a disclosure statement just to let you guys know that HMA does not endorse any specific vendors for telehealth platforms or equipment, though we do endorse the idea that telehealth is important and impactful in healthcare transformation. So for that reason, we do work with a number of companies in the digital health space. Next slide. So this is a list of all the webinars that we've had in this series. And as you can see, we've reached the end here today with the webinar that we will be having on use cases. Next slide. This is our panel of HMAers who have been supporting and developing content for this webinar series. And with that, Uche, the floor is yours.
Great. Thank you, Amanda, for taking care of the introduction and teeing it up for us for this session. Greetings, everyone. My name is Uche Uchendu. I'm a physician principal at Health Management Associates. Thank you for joining us. My guess is that some of you have attended one or more of our sessions before now. Welcome to new and returning participants. As you already heard, joining us for today's session are two special guests representing voices from Delaware, deploying telehealth in their respective organizations. I will start off with picture highlights of the series so far, then introduce use cases from the field and engage in an interview-style dialogue with our guests. Slide 7 outlines what you can expect within this hour. After our quick journey down memory lane on the series, you will hear from Beverly Lawson about the People's Place experience with telehealth and from Tracy Bolander about telehealth at MidAtlantic Behavioral Health. Before we move on, we will obviously leave time for comments and questions, and we'll tell you about next steps. And please don't leave early because I have a homework for you as well that will come towards the end. So we hope that you will be sticking around for that. Moving on to slide number 8. It's a snapshot from session 1 of our series. In this first part, Dr. Jean Glosser discussed Telehealth 101, definitions and terminologies, including options in digital health. During the second part of that session, as you can see on slide number 9, I discussed my experience with telehealth, including implementation at U.S. Department of Veterans Affairs, as I demonstrated the evolution of telehealth alongside improvements in technology on a wider scale. Additionally, I shared research on barriers to implementation of telehealth and connected the dots to challenges and opportunities in Delaware for greater penetration of telehealth. I also shared some thoughts on possible solutions, including exploring options beyond clinic video visits and embedding telehealth into organizational strategic plans. I concluded with a reminder that challenges should be opportunities, not reasons to quit. During the third part of the webinar one, as you can see on slide number 10, we heard from our guest, Carolyn Morris, about telehealth resources in Delaware. We also shared information on resources you can tap into beyond Delaware. On slide number 11, here I'm showing you select highlights from session number 2. Topic was digitally integrated primary care and behavioral health. We had 2 of our HMA principals, David Bergman and Laurie Remy, who delivered that session, and they expertly discussed the topics and on which they had also published. The image you see on the left side is copyrighted image from their publication. The integration technologies were grouped into 3 main sections: patient-facing technology, provider-facing modalities to build capacity, and virtual visits. That session also included information from American Psychiatric Association on evaluating apps, shown here on the right. Slide number 12 takes us to session 3 highlights. Session 3 was additional technology enhanced solutions. The live webinar was on January 16, 2019, a joint presentation we did on tech solutions for telehealth. With framework of functions, tools, and outcomes, we discussed clinicians' tools, patient tools, and caregiver tools. I presented e-consult and adherence, while Dr. Barry Jacobs and Dr. Greg Vachon gave us great insight into technology solutions for virtual caregiver support and patient decision support, respectively. Greg also discussed automated text messaging, and I shared information on the use of kiosks in telehealth. We asked lots of questions and hope that by the end of the series, you'd have more answers from our engagement. Why, who, where, how does it work? What are the benefits? When is it applicable? On slide number 13, contains a few more highlights from webinar number 3, showing you snapshots from the decision support, text messaging, caregiver support dialogues, and a word cloud that pulled out most of the keywords in the session. Try identifying them when you download the slides. On slide number 14, that's a highlight from webinar number 4. Telehealth reimbursement and payment models was the topic of that session, which included special details about Delaware. Many thanks to our guest, Carolyn Morris from MidAtlantic Telehealth Coalition. HMA colleagues Amanda White and Dr. Laurie Remy were my colleagues who did that session with Carolyn. Slide number 15 has a few more highlights from webinar number 4, including new exciting information about reimbursement. And in wrapping up, they pulled it all together with the slide you see in the middle. Determine local payer guidelines for coverage, including required technology. Review any applicable state or federal regulations, including patient education, consent, privacy, and security. Documents the service as if provided in person, including important billing elements such as face-to-face time, and reports the appropriate codes for individual payer policies. I paused to give you that highlight from this particular session because reimbursement is a topic that's on a lot of people's minds. I'm not going into the other details because the sessions are archived, and I'm hoping you will check them out to learn more. Slide number 16 is from 5th webinar, which was titled Telehealth Business Plan Development and Readiness Assessment. It was held on January 22, 2019. The session was a tag team presentation I did with HMA colleague Mary-Kate Brousseau. Mary-Kate kicked us off with what you need to include and how you go about telehealth readiness assessment, as shown on this slide. On the top right corner was a poll we had during that session where Mary-Kate asked if people were currently doing telehealth or if they had a team dedicated to telehealth. It was great to see that the positives were more than the no's. What we didn't tease into was what types of digital health engagements were they doing, and you will hear from some of our speakers today on that. I complemented that with telehealth business planning tools and options on the next slide. The mixture of business plan tenets with healthcare applications of business planning with a dash of telehealth yields telehealth business plan as product. I was trying to make a concoction there. We also shared HMA developed tools that can be applied to telehealth readiness assessment and business planning. The snapshot on the lower left side of the slide is from HMA 2 to support and guide clients who choose to engage our expertise for accomplishing this. Armed with your business plan, you can secure funding and engage stakeholders within and outside your organization to deploy or expand. You can also use this to market your telehealth program and plan towards sustenance. Again, you can access the archived webinar for more details. Slide 18 is from webinar 6. Our marathon of webinars continued with session number 6 last week, titled the Telehealth Vendor and Equipment Selection. Dr. Greg Vachon and David Bergman shared regulation and requirements and other key things to consider. Slide 19 is from the same webinar, included selection process without losing sight of hidden costs and unanticipated circumstances beyond the immediate cost. They also shared examples of identifying functions, doing a market scan, and figuring out specific requirements to perform the telehealth functions you want. Greg and David finished off webinar 6 by sharing use case scenarios as shown on the lower right corner of the slide. Notice the arrows go both ways in each of the options. Connection between provider and patient, connection between provider and patient at home is the first one, provider and patient at a health facility. And I'm going to pause on that because the question I'm posing for you at the end will relate to that particular scenario. And then provider to provider and system contacting patients. And you will see from my examples today where these fit in. Well, that was my highlights in pictures and a few words on the 6 webinars we completed in the series. We spared time for questions at each of the webinars, and some of you took us up on the invitation to reach out to us. We got some feedback and questions, including some procedural inquiries that, if time allows, we may be able to share some thoughts on with our guests. I would like to do a pulse check, clinically speaking. So, Samantha, please put up the poll question. I'll read it to you while Samantha sets it up. Oh, she's quick, it's already up. So select the accurate option below to complete the statement. And the statement says, today's webinar, so your option will complete it as, is the first in the Delaware Sim Telehealth Learning Lab webinar series, is the only webinar by HMA on the topic of telehealth, can be accessed in the archives along with other recorded sessions, does not fit any of the options above. I have a feeling you've already put in your answers, so we'll give it a moment and Samantha can close the poll. And here's the result. That's awesome. Everybody gets an A. Thank you for participating. 100% of you selected the correct answer, can be accessed in the archives along with other recorded sessions. The poll question was intended to check if you are still there. I'm glad to diagnose from the pulse check that you are all awake, alert, and paying attention, if I may borrow the lingo in the medical history taking. This is important because the next part of the session will answer questions that you're probably asking. You do not want to miss it. So now on to use cases. I will share a research that reviewed use cases for over 150 medical centers and their associated outpatient clinics. Slide number 21 is a snapshot summary of the utilization of clinical video telemedicine in the largest healthcare system in the United States. And if you said Department of Veterans Affairs, you are correct. In this January 2019 publication of the Journal of Rural Health, Scott Adams and colleagues did an observation study. They used Veterans Health Administration admin databases, analyzed trends in clinical video telemedicine utilization and types of care received. Among 7.65 million veterans from October of 2008 to end of September of 2015, they stratified trends by veteran rurality and analyzed data using linear regression. The population that had the higher odds of using clinical video telemedicine were rural residents, younger individuals, people who had a longer distance to go to the facilities, one or more comorbidities in their diagnosis, or people who traditionally had higher rates of non-video utilization. And the graph on the top shows which services telehealth was used for. These included mental health care, primary care, pharmacy, weight management program known as MOVE, and specialty care. Other was the catch-all for things that didn't fit into those categories. Notice that mental health care got the gold for most of the utilization, similar to the Delaware usage, where utilization is more so in behavioral health. It is therefore no surprise that the use cases we are bringing to you today from Delaware are from behavioral health. And that's my intro to the voices from Delaware. We have two esteemed guests today from People's Place at and from MidAtlantic Behavioral Health. Let's start with Beverly Lawson from People's Place. Bev, Bev, are you there?
Yes, I am.
Great. Bev and I will discuss some background information about People's Place in the form of question and answer, as Bev gives us more insights into their work in general and telehealth operations in particular. We have some visuals in terms of slides to share as we do this. We are now on slide number 22. So Bev, my first question to you is to tell us about yourself, your background, your role at People's Place.
Okay. My name is Beverly Lawson, and I'm a licensed professional counselor of mental health. I've been working at People's Place I'm in my 19th year here as the Director of Treatment Services.
Wow, that's wonderful. I know we agreed to keep it brief. That's not all about Bev, but you can reach out to her afterwards. That email will be at the end. So my next question is to tell us about People's Place, history, overview, your elevator speech about People's Place.
Okay. So People's Place has been around since we were founded in 1972. Originally, it started with all volunteers to address a drug problem here in Milford with our youth. And it became a little overwhelming, and they realized it was important to bring around the agency and bring in licensed professionals to address this problem. So it started out as that years and years and years ago, and we've just grown from there. We have 19 locations throughout the state. We have 10 different programs, about 150 employees with an $8 million budget. A lot of our programs are funded through the state. As you'll see on the next slide, we have a lot of programs that address many other issues besides mental health. And so we do receive some state funding. Of course, our counseling center started the whole agency and continues to grow. And we rely primarily on insurance reimbursement. The mission here, we're a nonprofit. The mission here is to help people find their path to growth and independence.
Wow, that's wonderful. It's amazing how People's Place has responded to the needs of the community in which they are situated and serving. So tell us more about the services provided by People's Place.
So our programs vary in service. It's all human service organizations. So we do have programs that focus on domestic violence issues. So we have shelters for women and children. We have a shelter that's specific for Latino women and their children. And then we also provide treatment for victims, for the children, also for an education program for the offenders. And then we have our Center for Community Justice, That is a primarily court mediation program, but it is a mediation program. Lots of our referrals come to that program through the court, typically first-time offenders where the victim and the offender have agreed to do mediation to avoid going through the court system. And they meet and they hopefully agree to a resolution. Sometimes that means restitution. It could mean community service, a variety of an apology letter, a variety of things can come out of those mediations. And also we have our family visitation centers, which is typically part of our domestic violence services. Most of our referrals come from a domestic violence case. So it's typically where either there's supervised visitation required, or it's also an exchange program so that they can bring their children and not have contact with each other. And then our group home for girls is a foster care group home through the state. Typically it's girls that are usually 15, we can take younger, and they stay with us until they age out of the program, hopefully graduate high school, and then move on from here. And that actually leads into our independent living program. That's a case management service for foster care children, but we also work with kids as they age out. So we help kids get into college, we help them get jobs and housing, lots of different things, a lot of training there. And we also have a homeless shelter in Dover, and it is open to males, females, and children. And that program is a 25-bed facility. And then our last program is our Veterans Outreach Program. It's a program that is a one-man show. He works with veterans to make sure they're getting the services they're entitled to. He goes to prisons to talk to veterans. He goes directly to people's homes. He's found homeless veterans out living on the streets, in the woods, and helped them also. And he does a lot of transportation for that program, so to medical appointments or other appointments. And he can pick them up right from their home and take them to their appointments.
Wow. Very important work that you and your team are doing for the people of Delaware. You mentioned Veterans Outreach. That got my attention and piqued my curiosity. Not sure if you know, but I worked with veterans at the United States Department of Veterans Affairs for very many years. So tell us more about the People's Place Veterans Outreach. What does that entail?
It's typically for veterans in Kent and Sussex counties. We've been providing this service since 1989. Originally, we were doing door-to-door transports to our hospitals, and we still can do that, but now the VA has opened locations in Kent and Sussex. So there are still times when the veterans can't even get to those locations, so we're able to help them with that. We also transport out of the state. So if they need to go to a hospital that's not located in Delaware, we can also make that transport. So we assist them to make sure they're getting the benefits they're entitled to. Typically, he's using his smartphone to make connections with the websites that he needs to get the information for the veterans.
Wow. Glad that People's Place is positively touching the lives of military service veterans in Delaware. It might be useful for anyone doing that work on your team, and it looks like you said it was a one-man show, to check out wellness and adherence support apps that we shared on webinar number 3 when we discussed additional technology enhanced solutions for telehealth. There are also peer-to-peer virtual support options that may be useful for the veteran outreach. From what you described, I'm guessing that your lead for that work is a veteran. Is that accurate? He
served in the Navy in the 90s. Yes.
Wow, wow. Yeah, I could hear from the passion and the nature of the work that he obviously was personal to the person.
He's a wonderful employee, but he definitely has that passion.
That's awesome. Shout out there to all the military service members and families. Great. A few more questions for Beverly Lawson from People's Place. You mentioned that counseling is the cornerstone of People's Place. It was on one of the earlier slides. Tell us more about People's Place counseling programs.
So we were the first program at People's Place, and primarily our main locations here in Milford. but we have expanded over the years since I've been here to other locations that are missing the services that we provide. So we're now in Millsboro, we're in Seaford, we're in Smyrna, and in Middletown. And at those locations, we provide therapy for families, for individuals. We see all ages. In certain locations, we provide the psychiatric evaluations and med management. And also in certain locations, we do other types of services like divorce and custody mediations, forensic work. We do co-parenting, parent-child reunification. We do all kinds of different forensic type services. And then also our local schools, we work very closely with them. We've been in the school systems now for quite some time, and we provide prevention and therapy services here in Milford to the elementary and the middle schools. Primarily, we take insured patients. We do have some funding to help with uninsured, or what I like to call underinsured. Anybody working in the field knows there's crazy insurance plans out there that people just, yes, they afford the premium. It's more catastrophic coverage, so we're able to help them when they have really high copays, and we want to make sure they get the services, and we don't want that to impede them from getting service.
Thank you so much, Bev. Can you shed some more light? I have a follow-up question. Shed some more light on where and how you are using telehealth to support this work.
So we use telehealth, telepsychiatry, telemedicine, everything for psychiatric evaluations and med management. That's currently what we use it for. We are starting to look at possibly doing providing therapy services in a similar manner.
Great, and the location looks like the asterisk was intended to highlight the locations where you have that.
Yes, Milford, Millsboro, and Smyrna.
Okay, that's great. My next question is about which modalities you're using. In the first webinar session, Dr. Jean Gorsa shared a slide that listed several digital health modalities. So I will show you that slide so you can select which ones you are using among them. Okay. So can you tell us?
So we definitely do telehealth virtual visits. That's definitely video conferencing those sessions. And then we also do direct to consumer. So we are doing reminders via text, reminders via email. We also now are doing reminders by voice. So those are definitely things we're already providing to our patients.
Great. So on the next slide, we'll pull out the two items that you just described, the two modalities that you are using, the telehealth virtual visit and then the direct to consumer. And my understanding from our prior conversation is that you're looking for ways to do more. Is that accurate?
That's accurate. In fact, I was thinking a little bit more. Currently, we use our mobile app for our employees. Are able to use a mobile app to access their schedule and that sort of thing. So my guess is there's probably something coming more for patients too.
That's great. That's great. So let's see. We have a few more questions for you to gain additional insight into your telehealth program. So I'll show them all at once and then we'll take them one by one. Okay. The first one would be, why did you decide to deploy telehealth at People's Place?
So in 2014, we were contacted by the Prevention and Behavioral Health, the kids department here in Delaware, and there was a governor's initiative to bring more psychiatry to downstate. So we actually ended up becoming the Kent County partner with them to pilot the service. It was grant funding that they received that paid us directly for paid the psychiatrist for the service. And so that's how we started it all way back then.
Wow. And then how did you come to the decisions you've made since then on telehealth implementation?
So that was exciting for us because it was new and innovative, and we were excited to partner. There were some little things that didn't work as well at that time, but after that program was done, we were able to, we had a psychiatrist that was on site who lived here, and she was moving away. And so we approached her to stay on with us by doing telemedicine. And so that's how it all started. We knew there was a need, there's a need anyway, and she was going to leave us, and we knew her, she knew us, she knew our system. It just was like the perfect storm. It worked really well. And so we've been continuing that since, I think it was 2015 we started, or 16, we started that with her. And since then we've grown to include psychiatric nurse practitioners.
That's great. And for everyone listening, you know, it's sometimes it's that organic. You're born out of need, you try something, and then you get more involved. And so some of our sessions, we talked about helping people not just for starting up telehealth and telemedicine programs, but expanding what they already have. My third question on this segment for you, Bev, is who is doing what? Tell us what processes you put in place.
So when patients call for appointments, for their first appointments, we explain telemedicine to them to make sure they understand that it's not sitting down in an office with someone, but the visits are virtual visits or video conferencing. And we want to make sure they understand that before we move forward. And so then when they come into their appointment, the clerical staff reviews, make sure they've completed forms that hopefully they've done through our portal. And that also explains, again, more about telemedicine. It gets a sign off from the patient saying that's what they want to do. So we make sure that's all done. The clerical staff might have to do vital signs for the patient. And then we take them into the telehealth room and we introduce them to the provider. Sometimes we stay in the room, sometimes we're back and forth, depending on what the provider needs us to do or what the patient wants us to do too.
Great. And then share some pros, challenges, lessons learned from your implementation so far.
So I definitely think the pros are that patients are getting services that they need. So, you know, I think that it's works well, and I think if you invest some time and effort in it, you can make sure that patients are comfortable with it. We have had very few patients once they have the first session say, it's not for me. I would say maybe less than 5. So people feel really good. I think the big thing for us is the provider on the other end is very compassionate, very kind and listening, and does a really great job with her patients, and all of our providers do. And I think that connection is what makes it work. I would say a con for us is not all insurance companies allow telemedicine. You have to really check people's benefits to make sure not only you have to describe it. Can the med check or the psychiatric evaluation be provided via telehealth? And is that allowable? And then will they also cover what is generated a facility fee, which happens because we're the originating site. So the patients come here to our location, so we can generate a facility fee. There are times when insurance companies don't cover that fee, although they allow the telehealth visit to occur. So they'll cover that portion of the fee, but then the facility fee would become the patient's responsibility. Another con for us is internet glitches, and unfortunately, if your internet goes out, your service gets shut down. So anyone who's experienced internet outage knows it's very frustrating, but it's also very difficult when you have patients here waiting to be seen. So that's probably one of the things we didn't necessarily anticipate. It doesn't happen very often, but when it does, it throws a wrench in things.
Well, thank you for sharing those. I think that last statement segues into my next question. Any process improvement you're planning or you're doing with your telehealth program?
Definitely looking at our internet options as far as a backup, maybe getting a hotspot, different things that we're trying to figure out that we could use in times when our main provider, internet provider, is not working. It's gotten so much better, so I don't know. It's just off and on at different times. So that would probably be one of the things that I would be focused on for improvement.
Well, that's great. I like how you're turning a challenge into something that you can improve. In webinar one, some of our conversation was that some people quit because they didn't think, some things were not working right. And also in that webinar, I shared research regarding internet connectivity in parts of Delaware. Interestingly, Delaware was better than many states, but it looks like there are patches of places where it's not so good.
Right.
So, yeah. Okay. So share what you can about your upfront cost and maintenance plans. I know you've mentioned some things about insurance billing, so maybe you just if you have anything more to add on that.
I would say that you're going to have your general costs. You have equipment purchase. You have to find the platform you want to use. You have ongoing costs, monthly costs to provide the service. We invested in a expensive blood pressure cuff and so that the patient can do a lot on their own when they go into the room. So bigger costs like that that you're going to have. The facility fee offsets some of that expense, but you do have additional costs with staffing and that sort of thing, but it's manageable.
That's great. So you're almost off the hook. Final question, at least prepared question, will be how about your staff and patient satisfaction from the use of People's Place telehealth services?
I would say that I actually have never, our patients do not complain. I would say if you were in a room and you had a little glitchy internet connection, there'd be a complaint, but they do not complain. They're just thrilled that they're getting the service. Again, then I think it's, we have the right providers. And so they make a connection really quick with their patients, and I think that's very key. Our staff seem to really do well with it too, and they're all excited that we're able to get patients in for the service, and so I think that kind of offsets any little issues you might have.
Well, that's great. It's always helpful when you have a team that buys into the process, and it makes things work better. And even when you have challenges, you told me when we were conversing earlier that when the internet went down, sometimes your staff will get water and snacks and things for people while they waited or figured out alternative ways to get the care taken care of.
The staff, I mentioned the providers on the other end, but just as key is having the right staff at the originating site too, that can help calm things when patients may be upset or come up with new ideas. They're very vocal about if they have an idea. So I try to listen to that too. So
thank you so much, Beverly Lawson. That was Beverly Lawson, Director of Treatment Services from People's Place. And Beverly will be sticking around for the remainder of the session. We'll be able to do Q&A at the end, and she'll be able to join us for that. So Bev, don't go anywhere yet. You can go back on mute, but we'll be calling you back shortly.
Thank you. So
next guest is Dr. Tracy Bolander, and Tracy is a CEO and licensed psychologist with MidAtlantic Behavioral Health. And I will give you a chance, Tracy, to introduce yourself. Can you hear me?
Sure, I can. Can you hear me?
Yes, I can hear you loud and clear. So go on.
Perfect. I'm Tracy Bolander. I'm a licensed psychologist. I also own MidAtlantic Behavioral Health. My background is I'm a retired teacher, and when I was a practicing psychologist, I was a forensic psychologist with a specialty in sex offenders.
Thank you. I know we agreed to keep it short, but again, Tracy has a website and her information will be at the end also. My next question to you will be to tell us about MidAtlantic Behavioral Health.
Sure. Much like People's Place, MidAtlantic Behavioral Health, bread and butter is therapy as well as medication management services. That is the bulk of what we do here. We are an outpatient. We are a private practice, so we are not an agency. We are a private practice. We have 4 locations. We have about 30 licensed providers. We see about 4,200 appointments a month. We provide therapy, medication management, assessment services, consultation services, and we also do integrated care in the primary care setting.
Wow, that's great, and I'm glad that we're succeeding in showing, you know, two different angles, and you're drawing out the contrast for us, and yet telehealth is possible in those different environments. You share some things in terms of the service you provide, but your setup is different. So thank you for pointing those out. I also would like to know how you reached the decision to incorporate telehealth into your practice.
Sure. We reached it very poorly. We did it kind of in an emergency situation. It was way back in 2000, want to say 2012, potentially 2012, 2013. One of our psychiatric nurse practitioners, who was the sole prescriber for children and adolescents, went into preterm labor and was put on bed rest. So we all know that there's an extreme shortage of folks to treat children from a medication management point of view. So I immediately reached out to our largest insurers because at this time Delaware had not passed the telehealth laws and it was not required. And we were able to get a special dispensation so that we could service their clients while she was home on bed rest. And so we actually just did it as a stopgap during that time. And then the same provider, ironically, her husband was transferred to Boston about a year and a half later. And so we decided that we would keep the same process, and she kept her caseload and she saw her patients from Boston. And we had another provider who did therapy, who took a position as a professor in Colorado, and so she kept working, seeing her patients for therapy. So the second time we went about it, we actually did it the right way. We took a very planned approach. We took the time to evaluate, did the market need it? What did the market need? How did we want to go about doing it? We actually evaluated vendors much more carefully than we did the second time. So those were some of the decisions. I guess I kind of dropped into the next block where we were really much more mindful in our decision making this time about what we wanted to do. And we continue to be that way. We look at it strategically each year about how we want to continue to grow it and why we want to continue to grow in that way.
That's great. Again, the stories tie up in terms of what pushed you over the edge is what I would call it. But I'm also glad that you talk about the deliberate effort, the second, call it the second time or third time around, I guess, in your own case, to work out how best to do it. And I'll refer our listeners again to Business Planning and Readiness Assessment, which was a webinar number 5. There's good information there. You also heard Tracy mention being deliberate about selecting vendors. And I think you have kind of tied up 2 of my questions, so I wouldn't ask why did you decide anymore, because you covered both of those. Which telehealth modalities are you using, Tracy? And here you have a cheat sheet from our webinar to select which ones you're using.
Gotcha. So we're definitely using the telehealth virtual visit for both medication management services as well as therapy sessions. We also use the telehealth virtual visits for our primary care collaborative consults. We also do direct to consumer. Our patients used to come to the office, but they no longer, most of our patients do not come to the office. They are at home for their visits, or on the road, or at the office, wherever the case may be, as long as they're in Delaware. And we also do, for our mobile apps, we do measurement measurement-based care, and so our patients are getting their outcome measures via the patient portal. They also get other things via the patient portal, like their labs. They'll get reminder text things about the refills being received, all of those things. And we are now using something called the recovery platform. And so they'll even get their random drug screens will come via a mobile app, their recovery platform mobile app, and they can see their scores via the dashboard.
Wow, sounds like you're growing leaps and bounds. Your deliberate efforts seem to be paying off pretty well in terms of your planning, and you're continuously assessing where you are and exploring new options. On the next slide, we pulled together, based on our conversation, the areas where you just mentioned. So to confirm, you have telehealth virtual visits, you have mobile apps, you have direct to consumer, and you also do e-consult. Is that accurate?
It is, and we are expanding our e-consult into we are a training institution, and so we are expanding our e-consult into the training that we do, but also into the partnerships that we have with medical residency programs.
Wow, that sounds great. You beat me to the punch, because I was going to do a follow-on to ask you which specialties you are consulting via e-consult. So I hear you mention a training program. Are there other specialties like that you are using your e-consult to reach out and connect with?
So the signed and implemented ones that we are doing are the two primary care sites, one of which is a residency training program, and the other one is also it's a clinic, but it's tied to an academic institution. And then we have another one in the works that is related to, we're going to start with primary care, but actually head into some of their specialty practices as well.
That's great. That got my attention because I did the e-consult for our webinar number 3, where we discussed additional telehealth technology enhanced solutions for telehealth. And typically people expect that in e-consult, it's the primary care consulting other people. So I'm glad to see you turn it on its head. It says so much about what people can do with telehealth. In your case, you're consulting primary care. Most of the time it's primary care consulting, the other specialties, cardiology and so on. So that's great. And if you're listening, as you can see, if you put deliberate effort into telehealth, you can do a lot with it. So
I forgot, years ago, we actually were part of a e-consult team for a Parkinson's clinic. So we were doing a very specific problem even, that we were working with an e-consult team. We provided the mental health piece. We were working with movement specialists out of Hopkins, as well as primary care. So there was a whole team that was doing it.
That's great. So you're almost there. I have a few more questions, and I'll put them all up at once, and we'll just go through them. I think there's 3 to go among our prepared questions. So where are you using telehealth, location and services?
So we are using telehealth at all of our locations. We are using it for medication management services, as well as therapy services, as well as initial visits and intakes.
Okay, that's great. And so do you mind sharing some of the experiences, pros, challenges, lessons learned? I know you've intertwined them here and there, but it would be great if you can pull out some for us.
Sure. So from my perspective, some of the biggest gains are that it certainly, much like Bev mentioned, it absolutely increases access to care. There's no doubt about it. When a patient calls and says they can't make it in because they don't have child care, or I know this would surprise folks, but maybe their ride didn't show up. We can get through that hurdle and they don't have to miss their appointment and then wind up calling in for refills and running out of medication and all of those things. So it really does increase access. It can also increase efficiency. I can have a psychiatrist that is seeing patients in my Wilmington office and seamlessly transition to an off-site primary care location, but those patients are scheduled back to back. So it really does increase efficiency. Also really increase, you can really manage your costs once you get to the point where you're not eating up office space for those clients. It really does help bring down those costs. We are also seeing a consumer demand. One of my favorite stories, because folks were like, oh, they will never do this for therapy, they'll do it for medication management because psychiatrists are hard to come by, is I had a patient who was seen for telepsych for medication management services, and as soon as she had her first visit, she was on the phone with me saying, why am I coming to your office for therapy? Don't you have anybody that can see me via telehealth for therapy too? And she immediately engaged in therapy via telehealth. So we absolutely are starting to see more and more of a consumer demand. We are actually starting to see a provider desire for this, that they would like to do telehealth. My provider that moved to Boston certainly had every intention of, and gets lured by every medical institution up there in Boston, but has so fallen in love with telehealth, she really feels like it is the best way to practice and has written a chapter in a book about it.
Definitely, for those who, who are innovative that way, there's still some traditional practices that feel the need to touch people, and I think there's a place for that as well. The matter of figuring out, what's best. And I used to
certainly
say that,
not right for every patient.
Yes, that's not best for every provider either. So finally, if you can comment on user feedback, return on investment, and any advice to others.
So our feedback has been very, very good. I think it ultimately is dependent upon the provider's ability to effectively engage a patient. I've gotten comments like, I forget I'm talking to a screen and not talking to the person face to face. So those have been some of the feedback that we've done, and I think ultimately that's the best thing that you need to do. The return on investment has been great for us as we've gotten more efficient in our approach. We have the same struggles that Bev mentioned. You often hear that Delaware has, one of the most telehealth friendly states, which it does on the surface. The problem is that in our state, most of the patients are in self-assured plans, and the laws that we have do not apply to those ERISA plans. So even though their card may say X, it may be prohibited by their employer. So one of the greatest challenges is figuring out who is and who is not eligible for the service. And so that would be something that I would say would be very critical for others to do. And then something else that I think is very critical is be mindful of your vendor. We saw a huge difference between the vendor we were using at first and the vendor that we are currently using, and it certainly makes our life much easier. And lastly, you got to have a champion. This isn't something that you can tell everybody, okay, now you're all going to do this, because they will sabotage it. You get your champions, and it's not one size fits all, and it's not going to be right for every patient. So it's nice to have as something in your portfolio, because the more tools you have to meet patient needs, the better.
Great. Thank you so much. That was Dr. Tracy Bolander from MidAtlantic Behavioral Health. And That concludes the interview with select voices from Delaware. We can now add session number 7 wedge to the picture on slide number 35, with titles of all the webinars in the Delaware STEAM Telehealth Learning Lab webinar series that HMA has been hosting, presenting. See green wedge on the far right, which now completes the planned sessions which spanned December 19, 2018 through today, January 29, 2019. We delivered key topics and content to support your adoption of telehealth if you do not already have it in your organization, and to assist those considering expansion. The box in the middle is the link to all the webinars, PowerPoints, and recordings. Today's will be joining the other ones now that we have inserted that wedge. Do not sign off. Like I said, I have homework for you. And but before I show you that, first I have to say thank you to our guest speakers. Can I have a round of virtual applause to our, for our esteemed guests? Today, Beverly Lawson, Director of Treatment Services at People's Place, Dr. Tracy Bolander, CEO and licensed psychologist, MidAtlantic Behavioral Health. Also, a shout out to Carolyn Morris, Chair of the Delaware Telehealth Coalition. You heard me mention earlier where she participated in prior webinars. Feel free to use emojis in the chat box in lieu of applause. And on slide 37, that brings us to the Q&A. And I'm going to move quickly because we don't have a lot of time left. But fortunately, we already have a question that is in the chat box. Someone typed, Uche, is Delaware VA utilizing telehealth technologies you have discussed in use by VA, or does that apply to DC VA? Do you know which of these telehealth modalities the Delaware is using? And Sam is advising our slides. She will go quickly back to slide number 7 because I devoted a little more time on my VA experience when we had the conversation. No, that'll be 9, slide 9. And the insert is on this slide, so I encourage you to listen to webinar 1. But directly to your question, if you look at the snapshot on the left lower side of this particular slide, those are all the services that are available at the VA, and they were rolled out at all the VA medical centers. The research I talked to you about was specifically on clinic-based video telehealth, which happens in all of those subspecialties listed here, but also the store and forward, which is asynchronous, is available. The apps I mentioned are available. The e-consult definitely available. We use that quite a lot, and we actually use that to regionalize. So yes, all VAs are supposed to have most of those elements, and each VA, part of the championing that Tracy was talking about, actually appointed a telehealth coordinator. So, and I know that there is one in the VA in Delaware, so feel free to reach out, and if you wish to contact me, I can also point you in the right direction. Thank you for that question. Sam, if you go to the appendix slide so people can see the homework before we lose some of them. But in the meantime, please type in your question if you have any, or unmute yourself both on your phone or on Zoom to speak. And there's a question from on the chat. Are you allowing therapists to work remotely if they are primarily doing teletherapy? I believe that's the question for our guest. Oh, and Tracy is on it. She responded on the chat that she does. MidAtlantic Health does. And People's Place has no problem considering it. So here we go. We're also matchmaking as part of this process. That's great. So please bring that in. I didn't see any emojis for the virtual thank you. Somebody at least oblige me with one, or at least say something. You were supposed to do a virtual clap for our guests today. And as you can see, they're both very engaged, including on the chat. The homework I mentioned before we hit the top of the hour is what is your current process for medication dispensing and or administration at the originating healthcare facility site, where the prescribing clinician is at a distance when the prescribing physician or clinician is at a distant or remote site. Please send your responses to me. My email is shown, uchendu@healthmanagement.com. The website for HMA is also there as well. So we are gathering information on this, and if you can help us with that, that will be very helpful as well. Tracy responded e-prescribing, Beverly responded e-prescribing. I'm looking at procedural issues on that. So I don't know, for instance, if the remote site is the clinician prescribing, the originating site, would there be ability to dispense medication or connect or administer certain medications? So we can follow up also offline. Like I said, my email is there and you can connect. So I want to make sure that we also close out very well. So going back on our closeout information, you can contact us for future communication, reach out to speakers to request additional assistance, look for our email, and please give us evaluation. That helps us see what we need to do better the next time and what worked well this time. Visit our website for information and check out the archives on the link shown. It's kind of long, so I won't read it to you. But if you pick up any of our past slides or this current one, which you will receive if you registered, just click the link and you'll be able to find the webinar. So with that, I think we're at the top of the hour. I want to be respectful of people's time. If you have additional questions, please feel free to send them by email. And if you have response to the homework, share with us as well. So thank you again for joining us for this series. That concludes our marathon of 7 webinars in about 7 weeks. And I want to thank my HMA colleagues, both the presenters and those who have been in the background making this possible despite the interspersed holiday season. So thank you again, and it was a pleasure being able to close out our series today.
All right, thank you so much, Uche. And again, big thanks to Beverly and Tracy for joining us. Everyone take care, thank you.
Thank you.